I want to welcome everyone to this really important event, and hope that everyone is ready for a really thoughtful discussion and presentation from Dr. Joshua Ellis. So I want to introduce myself and Claire, who are going to be co-hosting this event that's co-sponsored by the Program for Faculty Development and the Equity, Diversity, and Inclusion Advisory Committee. So my name is Ann Wong, and I'm a professor in the Department of Anesthesia at McMaster, and my co-host is Clare Wallner, Dr. Clare Wallner, who's assistant professor in the Division of Emergency Medicine, Department of Medicine at McMaster University. And we're both members of the Equity, Diversity, and Inclusion Advisory Committee, and we both also co-chair the Training Professional Development Working Group. And we want to thank Dr. Teresa Chan, the Assistant Dean for Program for Faculty Development, for her great work in initiating this collaboration and for inviting our keynote speaker, Dr. Joshua Ellis, as well as Dr. Naomi Thulian and Dr. Brenda Berkland, co-chairs of the EDIAC, as well as Dr. Mark Walton, who is Vice Dean of Faculty Affairs. So before we start this presentation, I'd like to acknowledge that McMaster sits on the traditional territories of the Mississaugas and Haudenosaunee Nations, as in within the lands protected by the Dish with One Spoon Wampum Agreement. So I'm just going to give a little bit of a background context to Dr. Ellis's talk, and then I'll turn it over to Dr. Wallner to officially introduce Dr. Ellis. So coronavirus and pandemic and Black Lives Matter movement have brought together the need for a major look at health equity. And it's important for us to develop a shared understanding of inequities in North American society. Decades of research in race health disparities have remained unaddressed and have shown little progress. And so Dr. Ellis will be providing some key examples of the magnitude and the variety of ways racism has impacted the health of Black Americans. And the initiatives and interventions that are used to correct for centuries of discrimination can also be replicated in other marginalized populations and countries, including Canada. And so we'll be looking forward to drawing from Dr. Ellis's experience and knowledge to have this discussion afterwards. So thank you very much for attending, and I'll turn it over to Dr. Wallner to do the official introduction for Dr. Ellis.
I'm very excited and happy to be introducing Dr. Joshua Ellis, who is joining us today. He is the current medical education fellow at Beth Israel Deaconess Medical Center and the Harvard-affiliated Emergency Medicine Residency, where he is also expected to complete his master's in public health at Harvard University. He completed his residency in emergency medicine at the Mayo Clinic and was a recipient of the Gold Stethoscope Educator of the Year Award and the Gold Humanism Award. He was also awarded the 40 Under 40 Leaders in Health Award by the National Minority Quality Forum in 2020. His interests are in health equity and the advancement of diversity in medical education. And we are very glad to have him join us today.
Thank you for the introduction. My name is Joshua Ellis. I'm currently in Boston, Massachusetts, which is about 5 hours south of Montreal. And I'm originally from Texas. But this is a lecture I've given quite a few times in a different version or a different lens. Particularly the Harvard Medical School. I first did the lecture as a resident at the Mayo Clinic for my Grand Rounds presentation. So it's pretty exciting and humbling to have this lecture now be given the platform to even have an international lens. And I'm really just humbled and grateful that you guys find this material and that I'm so passionate about something worthy of your time. So thanks to everyone for being here, and we'll go ahead and get started. And the title is Lessons from the First American Pandemic and Racism. And so first and foremost, we'll get started. No financial disclosures, unfortunately. However, I do have some biases. And so I'm actually half Mexican-American, a descendant of an undocumented immigrant, and half African-American. My father grew up in Texas. And this is we had a family of 4. And so if you look here to the left, that's our family of 5 children. And I have 4 siblings, and my youngest is severely mentally disabled. She's right there in the middle. And if you look to the right, this is the house I spent much of my childhood in. We were very low income, very much below the poverty line. And so much so that the last 2 years of my high school experience, we were considered homeless by the state, and I was busing into the district that I would eventually go to high school and complete my high school experience. And so I want to be upfront about the biases I bring, since that's a major theme of this lecture, and exactly how this my passion and desire to speak about this has come about. And so here are some of the objectives that we mentioned briefly. We're going to define the shared vocabulary regarding health equity, racism, and this is going to include this talking about individual versus structural racism. We're going to go through quite a bit of racial disparities that have already been demonstrated in the modern literature, and the variety of disparities is going to be the highlight of that theme. And then we'll talk about the concept of subconscious bias, as well as some interventions that have previously been implemented here in the United States that can improve health disparities, as well as some of these other metrics that we use in health equity. And lastly, we'll talk about the racial demographics that are important to U.S. healthcare. And hopefully you guys will be able to learn and take some notes from this with regards to some of the things that could be happening in Canada, or even just in general. And so a lot of these themes are very universal and can be applied to different marginalized populations. So let's get started. So first and foremost, the cost of the pandemic. Like we mentioned before, Black Lives Matter and the coronavirus has really brought this to the forefront of the American conscience, right? And so the pandemic has greatly impacted our minority and marginalized populations to a severe extent, so much so that African Americans are about 3 times more likely to contract and 6 times more likely to die from this virus. And there's absolutely no biological explanation for this. And so the question is this the virus that's killing them, or is this something that's been implanted into American society? And the structural components of our society are leading to this disparity. And it's actually not unique to American society. And so I had a brief, I'm no expert in Canadian healthcare or Canadian demographics, but here are some examples in which Canadians have had issues with race. And here's a Brian Sinclair is right there in the middle, a gentleman who died in healthcare, and also Joyce E. Chequan and Alan Adam. And so all these people have unfortunately had horrible incidences of racism, potential structural components of racism that have brought this to the front of our collective conscious, things that I've heard about in the United States. And so it's a universal issue that we're all going to have to come to terms with and get better at. So it's certainly important, and we'll go ahead and move forward with our vocabulary. So here are some of the terms we're going to talk about in the beginning of this lecture, and then we'll start with race. And so the big thing about race is that we want you and everyone to understand, as we talk about this in a health equity lens, that race is a social construct, right? There's no biological difference that would necessitate us clarifying our racial differences in a healthcare setting, except for maybe 2 to 3 illnesses or diseases, right? Otherwise, for the most part, race has been used as a proxy for other things, such as low socioeconomic status and et cetera, et cetera. But nonetheless, we definitely can't fail or forget about race entirety or fail to mention it, right? And the reason why is, like, we actually did a study in 2016, it was published in 2019, where we looked into Virginia's medical trainees. And so we surveyed all the medical students in University of Virginia. And we found about half of the white medical students in this program believe myths such as Black people have thicker skin or less sensitive nerve endings than their white counterparts. And so it's definitely something we do need to keep talking about, because there's still huge misconceptions. That's categorically false. But the alarming part about that is that these are people who have reached the pinnacles of educational success, right? People whose motives and desires to master and become doctorates in the human body and the physiology. And these are people who have these misgivings, right? And then we have to consider how much of these misgivings are implemented into this general society, your police officers, your judges, your accountants, and everything else. And so we do need to keep talking about it. And so while it's a race is a social construct, it's certainly still extremely relevant. And I'm actually pulling from a literature from Dr. Kamara Phyllis Jones. She's a civil rights activist as well as a physician here in the United States. And she has a landmark article titled A Gardener's Tale. And I encourage all of you guys to read this. She uses an incredible analogy of a garden to describe the impact of racism on our society. I think it's simple, but I think it's definitely it's a quick and easy read. But the highlight of the article is that she describes race not as a biological construct, right? It's a social construct, but more so is important because it captures the impacts of racism. And so it's something we can't forget, but it's very much intertwined with where we are as people. But for example, if we were to talk about the statistics behind coronavirus, we could actually state those who have undergone the experience of being Black in America, undergone the experience of racism in America, were 3 times more likely to contract coronavirus and 6 times more likely to die from it. And that's what her argument is that all these differences and disparities that we see within our races is actually describing the impact of racism on the individual. And so the next statement is, what is racism then? Right. And so now we have to define racism. And this is an even more difficult task because in American society, racism, or to be a racist, is one of the worst pejoratives you can throw at somebody. And I often make even somewhat in a joking lens that it's more harmful to call less harmful to call a minority a racial epithet than to go to a white person and call them a racist, right, in our United States. And here's a 2014 billboard in Arkansas, which is one of our southern states. And this was funded by a subgroup of the KKK in 2014. And here's an example. It says it's not racist to love your own people, and it's a white pride radio billboard, right? And what I've taken from this is that even white supremacists do not want to be called a racist, right? It's such a pejorative. It ends the conversation. It's not at all being applicable in the same way we're using it in colloquial terms. But then here's another example of which way racism is being used, or the word racist, right? And this is a show on Netflix. I think you guys should all have access to it. And I love this show. It's a shameless plug. I hope I can get sponsored by them one day. But Dear White People is it's first a movie and then a show about racial identity in a higher education setting. And this is Sam White, the protagonist, who's talking to the dean of students. And she describes, Black people can't be racist. Prejudice, yes, but not racist. Racism describes a system of disadvantages based on race, and Black people can't be racist since we don't stand to benefit from such a system. Now, I disagree with Sam in this conversation, but she is confidently speaking about the word racism in obviously a completely different way that the Ku Klux Klan was using in the billboard, right? And these are often used colloquial terms, one of the more common used terms in our language, and we have to really come to a shared definition. And I think in Kamara Jones's Gardner's Tale literature, she actually does this. And so what she actually describes is different types of racism. There's internalized racism, and we've all become somewhat familiar with this in terms of wanting to change our hair, our skin tone, and everything. It's a colorism within minority communities. There's personally mediated racism. And I think this is what the Ku Klux Klan was alluding to, right? The individual discrimination and prejudice that acts on somebody else. And then there's structural racism. And I think this is what Sam White was alluding to, this historic and societal disadvantages that are all encompassing in our society here in America. And so if we can have a shared definition of racism, we can begin to have the conversation on how do we address it, right? And so the bigger question is individual versus structural racism. And I want to highlight that the existence of one, or even the dominance of one, doesn't take away the necessity to address both of them, right? And so here's an example. We're going to cover cardiovascular disease in the United States. And cardiovascular disease in the United States is the #1 killer of all Americans here. And unfortunately, it disproportionately causes death in the Black community than any of its other racial counterparts. And this is data taken from the CDC in 2019. And if you look here at the chart on the left, the green line is African Americans and every other line is the other racial categories. And we're, throughout the last 2 decades, far and above African Americans, that is, have higher death rates for heart disease than any of our racial counterparts, and double that of our Asian counterparts. And we can look at all the risk factors for cardiovascular disease, such as hypertension, obesity, diabetes, and African Americans, which are the green bars, are above their counterparts in every category, except for diabetes with Hispanics, but still, very much so all the predisposing factors. And we have to ask ourselves why, right? We've once again defined race as we're dividing these categories. There is no biological difference or explanation that will justify these. And so we have to discover why. And the answer is structural racism, these institutional racism, structural racism, and the social determinants of health. And the SDOH is an acronym for social determinants of health. And we've done 2 or 3 decades of literature to discover that each and every one of these social determinants of health has an impact on an individual's health, and more specifically on their cardiovascular health. And there's a plethora of studies out there that state that low socioeconomic status which is over here in the economic stability, has deleterious effects on one's cardiovascular disease. But at the same time, we know that because of structural racism, the average white family in America has a $700,000 increase in their total wealth than the average Black family. And obviously, these are averages, but still, there's a great disparity in wealth in our country. And so, if there's a low socioeconomic, if being a low socioeconomic status is a predisposing factor for cardiovascular disease, then certainly African Americans would be more predisposed. And if we go down here to education, because of this economic differences, segregation, redlining, we know that there's a huge gap inside the education funding. And so because our funding for education comes from property taxes, there's greater than a $20 billion difference in the racial or studying the education funding for African Americans versus our white counterparts. And we can go over here to health and healthcare, right? Even after the Affordable Care Act, or more commonly known as Obamacare, African Americans are more likely to not have insurance or access to healthcare. And you can go to neighborhood and built environment. We know that redlining, segregation, the Jim Crow South, but also parts in the North, all have led to poor housing conditions. Food deserts are more likely to be in minority dominated areas. And also mass incarceration is more likely to be predisposed on our minority and underrepresented populations. And mass incarceration in and of itself is a huge part of the reason we have some of these disparities, not only because of the removing of the student or the person from their education, but the destruction of their economic stability, but also anybody in even a short stint in the criminal justice system in the neighborhood and environment has deleterious impacts on their cardiovascular disease and also their psychosocial health. And so we've seen all these things have a huge impact on our health as Americans and African Americans, but does that necessarily preclude our desire to remove or the existence of individual racism? And my argument here is that it doesn't, right? And we should all have an individual mandate to address individual racism, even as society is struggling with the structural components of racism at the same time.